அவங்க பண்ணணும் சார். ரகுநந்தன் பண்ணணும்.
ரகுநந்தன்
நீங்க பேசுறது கேட்கும் சார்.
ஓகே. ரகு ரகு அன்மியூட் பண்ணேன்.
எஸ் சார்.
நிறைய பேர் இப்ப அனுப்புற மெசேஜ் என்னன்னா லாக்டு பை ஹோஸ்ட்னு வருதுன்னு போட்டிருக்காங்க. ஸோ அவங்களுக்கெல்லாம் யூடியூப் லிங்க் அனுப்பிச்சிட்டேன்னு சொல்லிட்டு இருக்கேன்.
ஓகே சார்.
ஐ திங்க் லாக்டு பை ஹோஸ்ட் அப்படின்னுட்டு தான் மெசேஜ் வந்துட்டு இருக்கு. சரி பாப்போம்.
ஓகே சார். சார் we can continue, ஸ்டார்ட் பண்ணலாம் சார்.
சரி.
Physical evidence cannot be intimidated. It does not forget. It sits there and waits to be detected, preserved, and evaluated and explained. An exhilarating welcome to all the delegates over here. Myself, Raghunandan Ramnathan, pre-final year student from Tagore Medical College and Hospital, heartily welcome you all on behalf of Indian Medical Association, Medical Students Network and Junior Doctors Network, Tamil Nadu. Whereas every webinar and workshop allows the practitioner and medical students to learn and discover viable ways to improve their clinical skills on patient care. Here, today we are gathered to acquire knowledge and find panacea on medico-legal problems in the clinical practice. Challenges to clinical management are a fact of professional life. Every doctor must expect to become embroiled in complaints and claims from time to time and be prepared to justify why they did. Good medical practice is defensible practice, which depends upon staying within the limits of your own expertise, keeping up to date, conducting audit, ensuring your administration is effective, and patients are not allowed to slip through the net, that you communicate effectively with patients, and the medical records recall all salient facts relating to patient. I am honored to introduce the speaker for the session, Dr. Ravindran Krishnamurthy, one of the most acclaimed senior police surgeon in Tamil Nadu, having 44 years of experience in forensic medicine. He joined Stanley Medical College in 1991 to broaden the knowledge of students. He served as professor and head in various government medical colleges and retired in 2002 from Government Keelpark Medical College and Royapeta Hospital. Then he joined Pondicherry Institute of Medical Science and worked there for 6 years as professor and head of forensic medicine and also as additional medical superintendent. He was a core committee member in National Disaster Management Committee during 2004 tsunami. He adorned various designations such as medical superintendent and dean in Chettinadu Health and Research Institute. He became the vice chancellor of Chettinad University in the year 2014. Now, he currently serves as academic dean and head of forensic medicine in Tagore Medical College and Hospital. Sir is an inspiration for many in the field of forensic medicine who has been nurturing knowledge all through his career, quoting all his real-life experiences that he has encountered in his profession. He makes even the boring talk impressive. Everybody knows that in spite of best care and attention, treatment can go wrong. Still, doctors are accused of negligence and in some cases punished by courts. Due to the increasing awareness of common public, thanks to the development of electronic media, people are resorting to legal actions whenever the expected outcome of the treatment by doctor fails to materialize. They allege negligence on the part of doctors while treating them. How to face these medico-legal problems in professional life? Let us learn that from our distinguished speaker.
Good morning to all of you. Thank you very much for giving me the opportunity to share my thoughts as well as experience in this very interesting field of forensic medicine and toxicology. Even though forensic medicine is considered as a subject in the preclinical side or in the non-clinical side, it is essentially having a lot of work in the clinical side. We cannot separate forensic medicine from the hospital practice. Whatever we try to teach in our classes pertains to the various aspects of medical practice. What are the things you have to do? How you have to safeguard yourself? How you can protect yourself from the prospective litigants? And all these things we are trying to teach you. I still remember an ENT professor by name Dr. Lakshmanan, who was serving in Stanley Medical College. In one of the farewell parties organized by the students, he said, "My personal advice to all the students assembled here is, you need not study all the subjects very seriously. You can study for your exam purpose. But please learn forensic medicine thoroughly, because it's the only thing which is going to follow you as your own shadow." I was just thinking, probably he got into some problem, litigant problem, because of which makes him say so. But he is right. Whatever may be your specialty, whether it is going to be general medicine, surgery, ENT, psychiatry, cardiology, neurosurgery, anything, the moment you start examining a fellow human being in the hospital setup, or in your own clinic, or in a nursing home, the problem of medico-legal work starts simultaneously. Starting from the moment you are going to take up the hand of the patient and feel for his pulse, the problem starts. If you are going to be little complacent, or you are going to be little taking it lightly, we do not know when we are going to hit the, when we are going to face the problem. But we have to see how to avoid these things, what best we can do. So that is the thing I am trying to focus on this today's interactions. I have been in forensic medicine. I joined my PG in the year 1976. From then on, I am in forensic medicine. I have taken it with, I have taken the subject, that is, I relish the subject. I relish my practice, forensic practice. With the result, I have seen lot of cases pertaining to the hospital side. But today, anyway, we will, to start with, I will first go through the normal thing which is expected of you in the hospital practice, and then probably I will deal with some of the practical things which Raghu was highlighting, some of the practical things which I have come across and how I have got over that problem. The only thing I would like to impress upon you is there is nothing to worry about. You need not fear about anything like a court, police, or public. All these things you need not worry about. I will tell the little tricks which you have to follow while you practice, which will take you a long way very safely, as I have done in my entire career. So, to start with, we will the role of the doctor in the casualty. So, what is it we are doing in the casualty? A doctor does in the casualty is he examines cases, various cases, both MLC and non-MLC. That is the most common part of everyday medical practice. What are you going to do with these MLC cases and non-MLC cases? The non-MLC cases, after the initial cursory examination, you will refer them to the appropriate specialists for further treatment. You are going to call the people, concerned specialties, and you are going to refer them to the thing. There ends your job. But regarding the MLC, if you are working in the casualty, the MCA Act specifically states any registered medical practitioner can treat MLC case. Whether it's an MLC, non-MLC, you can treat the case. There is no harm. And how you are going to proceed with? To start our practice, we require two set of standard forms. One is called the accident register. Other is called the intimation to the police. These two are probably you can call the Bible in that casualty. Accident register and intimation to the police. And this accident register and also the intimation to the police, they have to be numbered consecutively. This is very, very important. You just can't have an unnumbered accident register and tear off the pages as and when you like. Because subsequently when the case goes to the court, if this type of a thing, if they see a numbered version, if the numbers are continuous, then there is no suspicion on your part. If it's an unnumbered book, they will say you have deliberately tore off some pages and you have introduced something new. So to avoid that type of an accusation, we have to have numbered books. That is most important. Accident register will be in triplicate. 111, 222, like that, 1 to 50 or 1 to 100, you can print the books. Intimation to the police will be 11, maybe in duplicate. So the sequence of chain of events, this pertains to the living person, the broad dead individuals, to the casualty. So what are the procedures we have to follow for the living individual, and what are those things which we have to follow for the broad dead cases? First, we will see about the living person. Living person, the accident register entry has to be made. In that accident register, you will have to write the time and place of examination. Second thing, whether that living individual is of a sound mind, right? Compos mentis. Then you describe the injuries and the characters of wounds. But for the broad dead cases, you do only an AR entry. You are confirming death there. And then you make an AR entry, body brought by whom, and what is the thing. And then you intimate the police. You intimate the police. Regarding those living individuals, also you have to intimate the police. But there are certain cases in which you can hold back the intimation to police. That I will tell what are the things you will have to, those conditions in which you can avoid that. So the next thing is for the living person, time and place of examination. Suppose you are doing it in the casualty of Tagore Medical College, you are going to write 10:30 a.m. Tagore Medical College Casualty Department. You have to mention 2 identification marks. 2 identification marks can be in the form of a mole. Usually you do it in the exposed parts of the body. A mole on the forehead, a mole on the nose, a mole on the cheek, a mole on the dorsum of the hand. But don't write this type of an anatomical terms, because the police and the court are going to peruse. They may not be very familiar with our medical terminology, medical jargons. So a mole on the dorsum of the, instead of the dorsum of the hand, back of the left hand. Like that, exposed parts of the body. Don't write some mole on some his private organ. That type of thing should be totally avoided. Or a tattoo mark can be mentioned, or a scar, an old scar, permanent scar can be mentioned as a identification mark, right? And if no marks are made out, there may be some people in which there will not be any visible identifiable marks of identification. Then you are going to take his left thumb impression, preferably in the India ink or the black ink, and you roll it on the accident register itself, right? Instead of writing no identification mark could be made out, you mention that, and then you take his fingerprint, left thumb impression, and then the soundness of mind to be ascertained by the doctor and recorded in the AR. This is one important part, because the patient may be brought in a stage of full consciousness or semi-consciousness or totally unconscious. So if he is conscious, how you are going to ascertain that he is of a sound mind? He is not confused. So you put simple questions to him. What's your name? Where do you live? Where are you coming from? What happened to you? Who brought you to the hospital? These type of questions. In case he is able to answer, I think he is of a reasonably sound mind. So you can record that soundness of mind ascertained by simple questions, and you are going to record it. If the individual himself gives a history, if the individual himself gives a history, there is no need to mention the soundness of mind, because a confused guy may not be able to give. This fellow will very clearly tell, sir, I was traveling in the bus. The bus was approaching this place. I tried to get out on the bus. That time one scooter wala came and knocked me down. He will give a very clear history. So there is no need to mention he is of sound compartment, sound mind and all. So the doctor, if he simply puts that patient is conscious and oriented, that's adequate. And orientation, where have you come to? Fine, that's a reasonable answer. Or he says, I have come to this hospital. This looks like a hospital. Only thing I do not know which hospital it is. Then you ask him some simple questions. What did you have for your breakfast? What is 3 + 2? What is 5 minus 4? Like that, you put some simple questions. She answers that. She is fully oriented, and you are going to mention patient is conscious and oriented. So that is how you check that thing. And one very important thing I would like to mention here is this we had come across while I was working in Pondicherry. I have come across a case in the casualty where the person came and he was admitted. Pondicherry Institute of Medical Sciences is a private hospital, so somebody paid the advance money as demanded by the hospital, some 5,000 rupees or something. This person states that he was driving the scooter, some dog or something, some buffalo came, so he hit against that and he has fallen down, he has sustained the injuries. And somebody brought the case, and Yar Kuti Tonda, I came on my own. I know this place because I am residing only in a close by area. So the doctor had no reason to suspect what has happened. So he has noted down everything. He was admitted in the hospital because he was complaining of some sort of a pain in the leg. Next day, the concerned specialist orthopedic surgeon examined him. Then he said he sustained a fracture, a closed fracture, which requires some internal treatment, a further treatment, which will cost about 25,000-30,000 rupees. Then this fellow started telling, Ayyo, I am not, how will I pay this money? I don't have any money. Then the doctor questioned him. Then how come you got admitted in the hospital and all? Then he is coming out with the story that some car fellow which was proceeding towards Madras from Pondicherry hit against him and he has sustained the injury. The car fellow took him in the car, told him, don't tell anybody that you are hit by a car. I will take care of your treatment, but unnecessarily don't give anything, any news to the hospital or something. And I will look after your this thing. So after paying that initial deposit and after saying bye-bye, this car fellow left. Next day when this fellow was told the cost of the treatment, etc., then this fellow became very panicky. Then his whole village came, started pressurizing us. Sir, Pavan sir, please change the thing and all. We said nothing. They asked me, as I was the additional medical superintendent, they asked me. I said nothing doing. We will not change anything. Accident register cannot be tampered with. Otherwise, we will be questioned by the court. We will be punished by the court. So we can't do anything. Then these fellows were going on asking what to do. Then I suggested you go to the police directly and you give your actual original history to the police. Let the police come and tell us. Then we will tell them, this is the one, this is the same guy who has come with this type of history. You find out. Let the police deal with the case subsequently. So that's why I am telling you, you never make any changes in the accident register. It is always a good practice in government practice. You don't overwrite in any certificate, whatever be it, injury certificate or the accident register or any other thing you are going to issue, your treatment, don't overwrite. In case there is a mistake that has crept in, you strike off that particular sentence or particular word or line. You strike off that and then you sign. Your signature is very, very important. And then you will write it again clearly without mistake. Courts accept this, but don't try to overwrite, which they say you are tampering with the record. They will use the word tampering the record. So don't do that. Any day, it is always a good practice, even for your other dealings, official dealings also. In case a mistake has crept in, don't do a correction there, overwrite. Strike it off. Put a signature. Then you write it. That means you have made the correction yourself. Nobody has tampered with your record. So you have to, this is about the entry in the accident register. Then what are the various characters of wound which we are going to examine in our day-to-day practice. The characters of the wounds are closed wounds, open wounds. We will broadly classify into closed wounds and open wounds. Closed wounds are non-penetrating, like abrasions, contusions, hematoma, and open wounds are incised wound, lacerations, penetrating wound like a stab or a punctured wound. Penetrating wound is again divided into two types. A simple penetration without exit, that is called a penetrating wound, if you remember. Perforating wound with exit. Perforating wound is having a wound of entry as well as a wound of exit. But a penetrating wound will have only a wound of entry, right? And simple penetration without exit and perforation with exit, a disruption or blast. These are the various characters of the wound. What is the medical classification of the wounds? As you have studied in your injury topic, blunt force injuries, which comprises of the abrasion, contusions, lacerations, injuries caused by sharp cutting weapons, called the incised wounds, then stab wounds by the piercing weapons. Stab wounds by the piercing weapons. So the incised wounds, incised stab wounds are caused by sharp pointed weapons. Sharp pointed weapons like a dagger, a penknife, a bichua, etc. Anything which is sharp can cause this stab wound, incised stab wound. There is another thing called the lacerated stab wound. They are caused by the blunt pointed objects. Blunt pointed objects like a cycle spokes, a screwdriver, or the rib of an umbrella. All these things can also cause the stab wound, but they are called the lacerated stab wound because the shape is not very clear like an incised stab wound. One most important thing you must remember in your day-to-day practice is whenever a stab wound is there in the casualty, do not probe the wound. You need not probe the wound to ascertain the depth of the wound or to find out which organ it has entered. Because you are likely to disturb some area might be actually be bleeding and a clot might have formed and it might be sealing that rent in that internal vessel. By probing, you may dislodge the clot, giving rise to a fresh bout of bleeding and a consequent death in the casualty itself. So stab wound should be probed only in the theater. Only in the theater where all the facilities are available. So a stab wound should not be probed in the casualty in a living patient, right? So then the injuries caused by heavy cutting weapons, they are called the chop wounds or the cut laceration. Then the traumatic amputation and decapitation. Decapitation means the head and neck, head is separated from the body at the level of the neck. They may be complete or they may be partial. This amputation, etc., may be complete or partial. Then firearm wounds, all the injuries should be described with reference to the size and anatomical location. Pheromones are slowly becoming more and more nowadays in our state also. And the injury should be described clearly with reference to the size and anatomical location. But in all these things, one fundamental thing is you examine the case and his condition is pretty precarious, serious. You give the treatment to stabilize the patient. Then you can concentrate on this recording of injuries and all those things, filling up the accident register. Don't fail to call the concerned specialist, concerned surgeon, orthopedician, physician, or even the anesthetist. Bring them in to the casualty. Let them see the case. First assess him, give him the first aid, start all the measures to resuscitate the patient. That is more important than recording these injuries. Once the patient is stabilized, then you can start writing the records. The moment the patient comes, you are going to write the name of the patient if it is known and brought by whom, those particulars. Description of the injuries can wait because life is more important than these injuries. In case you are going to be questioned in the court at a later date, why there is you have not done this, that, and all, you can say patient condition was very critical, so we wanted to resuscitate the patient, so his treatment was taken up. Once he was stabilized, we have recorded. That's why the delay. Any court will accept that, and nobody will find fault with you. And we will see the injuries, various types of injuries, a brief revision. Abrasion. What is abrasion? It is an injury to the epidermis. It is an injury to the epidermis is abrasion. What are the various types? The scratch, the graze, the imprint or the impact abrasion, the pressure abrasion or the pressing abrasion. So what is the scratch abrasion? These are the types of abrasion. What is a scratch abrasion? It is caused by any sharp pointed object like a pin or a needle or the tip of the knife. All these things can cause a scratch abrasion. What is a graze abrasion? A broad area of skin is rubbed against a rough surface like the road. So you will see multiple parallel lines due to drag on the rough road, usually seen in road traffic accidents. Then the imprint or the impact abrasion is the one which happens in head-on collision, where the radiator grill will be seen or the tire mark will be seen on the body. Then the pressure abrasion or the pressing abrasion, which you see as a ligature mark in hanging cases and strangulation. That is the pressure abrasion. All these abrasions are caused by the movement of an object with a rough surface over the skin. And you have to differentiate whether it's an antemortem abrasion or a postmortem abrasion. Antemortem abrasion will have that areas of bleeding, and the consequent discoloration. But postmortem abrasions are pale white in color. If a dead body is dragged on the floor, then also you will get an abrasion, but it will be pale white in color and there won't be bleeding. And usually it is caused by ants. Usually we will see it caused by ants. Then contusion. Contusion, otherwise also called the bruise, is the extravasation of blood below the skin. Collection of blood below the skin. When the blood is collected, it is known as hematoma. You will see as a swelling, and probably you can press on it also. It can appear on the side or away from the side. It drifts away because it's actually bleeding that takes place. It finds the planes in between and it appears in a different area. And how does a contusion looks like? There will be a swelling. If you press on that area, there will be a pain, tenderness, and there will be a discolored area, especially appreciated in fair-skinned individuals. The one very important thing about contusion is it is an antemortem phenomenon. There is nothing called a postmortem contusion. Don't occur due to postmortem violence. It is an antemortem phenomenon because the blood vessels rupture and the bleeding takes place. There is extravasation of blood. As you all know, immediately after death, the circulation stops. So there won't be any active bleeding. So contusion is an antemortem phenomenon. The recent case also in Satankulam case, you must have read in the papers that there have been multiple contusions on the back of the individual, starting from the shoulder down to the gluteal region and back of thighs, etc. Multiple contusions are seen. Nobody can now say that these contusions were all caused by something else. I will come to that description sometime later, but contusion is an antemortem occurrence. It is not a postmortem occurrence. Please remember that, right? And next is laceration. The laceration is the edges are irregular with the surrounding abrasion and bruises. The deeper tissue is torn irregularly. Laceration, you must have seen many a time in life we get this laceration and the edges are irregular. It is due to a fall or due to some assault with some irregular weapon, irregular shaped weapon. So what is the thing is, it is not going to occur alone. It will have a surrounding abrasion as well as a bruise. And the deeper tissues, namely the subcutaneous tissue, etc., will be torn irregularly. What are the types of laceration? We have an overstretched laceration or the avulsive laceration, where the skin is totally avulsed. So it will be lying limp so that you can stretch it and pull it over. You will see the whole thing will be covering. But if you release it, if you push it, it will come up to the middle of the forearm. So that's the avulsive or the overstretched laceration, resulting in deglowing of the skin. Then crushed laceration. Crushed laceration usually takes place in the accidents, run-over accidents. Here, partial or total amputation may take place, depending on the fracture of the underlying bones. All the tissues, starting from skin to the muscle in the bone, they are all crushed and separated. So that is the crushed laceration. Maybe the partial or total amputation can take place. And then we come to the cut wounds. The cut wounds are again divided into incised wounds and stab wounds. Incised wounds are clean cut and gaping wounds. The natural phenomenon of our skin living individual is the elasticity of the skin. So if a cut is made, the skin gapes. So the edges are, but the knife edge is very sharp. So if you are making a cut, the edges are clean cut and gaping. The proximal end is deeper, the distal end is tapering or tailing. That means if you are going to make a cut like this, to start with you will apply more pressure, and then while you come down, your pressure wanes off or it decreases. with the result, in the proximal starting point, it is deeper, but when it comes down, it becomes more and more shallow. And suppose you still drags it further without any pressure, you will have the tailing of the wound. What is it used for? To find out the direction of the wound. In the incised wound, what is the characteristic? The length is greater than the depth of the wound. And it has no relation to the length of the blade. Because even if it is a small shaving blade, one can cause from here to here, from your shoulder to your forearm, or your back of hand. Somebody can cause even with a shaving blade. So length has no relation to the length of the blade. Next is the incised stab wound. The weapon which is used to cause an incised wound, like a knife. Probably with a shaving blade, don't ask me whether you can cause a stab wound. It may be very difficult. You should be an expert. Only then we can do that type of a job. Otherwise, it's not possible. But a knife, a bichua, etc., you can cause a stab wound. Not only an incised wound, you thrust the thing in some hollow cavity, it is going to produce a stab wound. So the depth of the wound, incised stab wound, the depth of the wound is equal to the length of the blade. You follow? If imagine this is the knife, this is the blade portion. If you are going to insert like this, if you are going to stab, that is going to constitute the depth of the wound from the surface of the skin. It is going to be equal to the length of the blade. The depth of the wound is greater than the length and breadth of the wound. In case it is a stab wound, the wound will be like this. This is the length of the wound. This is the breadth of the wound. And this thing is the depth of the wound. So the depth of the wound is greater than the length and breadth of the wound. The length of the wound and the breadth of the blade is more or less equal. The characters of the stab wounds, they have a definite relation to the weapon used. Characters, they have got a definite relation to the weapon used. So by studying the wound, we can to a certain extent guess what is the weapon that has been used. Lacerated stab wounds, similar to the incised stab wounds, except the entry wound is slit-like or oval shape or round. Because I told you about the umbrella rib, I told you a screwdriver, all these things can cause a penetrating wound, but the thing is, it is going to be a slit-like or oval shape or round with irregular bruised margins depending on the weapon. Because a sharp-edged weapon will not cause that marginal bruising, etc., to a very great extent. But these irregular weapons with irregular edges can cause the marginal bruising. And next is the firearm wounds. Nowadays we are getting more and more cases. During my active period, these things were not that much. But nowadays, because of the availability of firearms with the license and unlicensed firearms also, we are getting quite a number of cases. So what is our duty when a firearm injury is there? If the person is alive, you immediately ask for a whole body X-ray. Person is alive, of course, apart from stabilizing the individual, taking his pulse, BP, all those things, start IV fluid, everything you will do, and then you take a whole body X-ray, because you will have to find out where exactly the missile has lodged. X-ray will definitely reveal that position of that projectile, so that it will be easy for the surgeon to remove it. But nowadays, the difficulty we are facing is the police are using what is called the rubber bullet or the plastic bullet. They say it is only to scare away the crowd. They say it is only to scare away the crowd, disperse the crowd. They say it will not kill. But my experience was different. While I was working in Government Private Hospital, there was a procession on the beach road by a political party. There were some skirmishes. The police fired them after the tear gas shells. They fired, and one fellow was brought dead. Two fellows were brought dead actually. One fellow, first we took him for exam, and the police gave the requisition that he was found dead. They were trying to suppress the entire firing history. But we got anyway from the papers and other things, we get the news. Those days, this internet, WhatsApp, all those things were not there. So we saw the paper next day only. So we saw. So we sent the body for whole body X-ray. The radiologist reported no foreign object found in the X-ray. Fine. Police were emboldened. They were telling, "Nangadan sonname sir, unnu kadayadu sir." And if at all we use only a rubber bullet, which is not going to kill. This fellow was assaulted by somebody. All these things. Then we started the postmortem. There was one area on the back by the side of the lumbar vertebral region. There was a small area of some piercing wound like. So we dissected out, and then we probed that area. We could find out a plastic bullet. A plastic bullet. Then I told the police, "Idukku enna sir artham?" This is plastic bullet, sir. Oruvela pattirkalam, but idunala saagala. He is again trying to come to it. But what has that plastic bullet done is they have fired, and it has entered through the back, from the back, and it has pierced that vertebral muscle, and it has pierced the IVC. With the result, there was an extensive collection of blood in the abdominal cavity, peritoneal cavity, nearly 2 liters of blood. And then how come the plastic bullet was missed? Is it radio opaque or radiolucent? We have to, I don't want to close the chapter at that level. So I took the plastic bullet, I went to the radiology department, I requested the radiology professor, "Sir, I have brought the plastic bullet. Please take a X-ray of it." "Eduk sir, idu varad paathuruvom sir. Let us not take any chance. We will see it." So we took the X-ray of the plastic bullet, and out came the X-ray. We can see it as a small civilinga. That plastic bullet could be seen. Then this man was taken aback, our radiologist. Then he started comparing his previous X-rays, and there that was made out. That shadow was there, but he thought it is some other shadow. It's not relevant to any of the anatomical structures, and he never contemplated this, because of course it's a white plastic. With the result, a very thin shadow was there. So he was very thankful. That is why we have to take a X-ray. And many a time we use what is called, people use what is called as the shotgun. shotgun is not one single projectile, multiple small balls will be there, lead balls, that will all create this thing, multiple entry wounds. So we have to see. And then another important thing is, some of you may be very familiar with the firearms, and you may say, hey, this should have been caused by this should have been caused by this. But do not volunteer the type of firearm used, the bullet found, or the range of the weapon, right? It's all to be answered by the ballistic experts. There is one separate wing called the ballistic wing in the forensic medicine sciences department. They will do a test firing and all those things, and they will give the opinion, right? Our job is to say whether the person has died due to this particular projectile or missile or the bullet. That is the only thing we have to give. In that particular case, I have given died due to the injury to hemorrhagic shock due to injury to inferior vena cava caused by a plastic bullet. I have given the opinion in that case, right? So that is the thing about the firearm wounds. Next is the age of the wound. Age of the wound, again, the casualty medical officer sometimes you have to see, especially like Sathangulam, where persons are kept in police custody for 2 or 3 days and then brought to the hospital. You see multiple injuries and you will have to give the opinion. In that, you will have to give your opinion with regard to the age. How can the age be determined? The age can be determined by the color changes in the abrasion and contusions. You have seen the various color changes that can take place even in your own life. If at all so far you have not observed, henceforth you observe in case you sustain some injury. We can determine the age from 24 hours to 7 to 14 days. 7 to 14 days. A fresh abrasion, probably up to 12 hours, will be red in color. There won't be any scab, right? There won't be any scab. And if it has crossed that 24 hours, it will be brownish. In 12 to 24 hours time, it forms a dark red scab. Up to 12 hours, no scab. 12 to 24 hours, you will have a dark red scab. Then 1 to 2 days, you will have a brownish red scab. Scab na the pakku katradunu solluvaanga. So that will be 1 to 2 days, and then 3 to 5 days. 3 to 5 days, dark brownish red scab, and 5 to 7 days, the scab starts shrinking from the periphery. You must have noticed it. Suppose they have fallen down, sustained an injury, abrasion, you would have seen the scab start shrinking from the periphery and then it falls off in 5 to 7 days. This is about the abrasion. Contusions, again, it appears dark red in 12 to 24 hours. The color changes in contusion can well be appreciated in fair-skinned individuals than dark-skinned people. The contusion dark red in 12 to 24 hours, then it changes to a bluish color in 1 to 2 days time. 1 to 2 days time, it changes to blue. Then it changes to a greenish color in 3 to 5 days. 3 to 5 days, hematoid. And then yellow. Yellow color between 7 to 14 days. The bile pigments. Blue is the reduced hemoglobin. So this is the changes that take place in the contusion. And after that, its color gradually disappears after 14 days. But in between the period, between 2 to 14 days, exactly as I said, it will be blue, it will be greenish, it will be yellowish, you can't. It is all will be a sort of a mixed color or vague mixed color. We call it as a variegated color. Variegated color means it's a mixture of everything. So that's about the contusion. For the sutured and non-sutured wounds, on the margins, the separation of edges and the scar formation, we can still say the age. Unsutured wounds, the inflamed skin edges up to 12 to 24 hours. Then appearance of infection. Suppose fellow is not getting any treatment, not applying any ointment, nothing happens. Then infection appears in 36 to 48 hours. Suppose if it's a sutured wound, what is the thing? The inflamed edges will be seen in 12 to 24 hours. Then the wound can be easily separated in 1 to 3 days. Suppose you cut open the sutures, you separate it 1 to 3 days. But beyond 3 days, 3 to 5 days, the edges are difficult to separate. Then a red linear scar forms in about 7 to 10 days. 7 to 10 days, red linear scar. Then a pale, firm, non-tender scar. Pale, firm, non-tender scar, more than 4 weeks. More than 4 weeks, you will see the scar. So this is about the various color changes, and you can still give your opinion regarding the age, but all this can be only approximate. You can't be very definite unless and otherwise you are the person who has inflicted the injuries. It will not be possible for you to tell with exact definiteness the age of the wound. Then this is another very important part, the filling up of the accident register. After examining the patient, as I told you, life of the patient is more important. You are going to give a lot of importance to the safeguard, save the individual, and then only you are going to donate your time, you allot your time for filling up of the accident register. So after examination, after stabilizing the patient, the doctor should note down the injuries carefully in the accident register. You will write down what are all the investigation to be done. Suppose he is having a very bleeding injury, actively bleeding injury, you will have to ask for a blood group, grouping cross-matching. He may require blood, or he may require x-rays to rule out any fractures. Note down the injuries, write down the investigation required, and prescribe the further course of treatment. Starting from injection, tetanus, topside, antibiotics, IV fluids, all these things you will write. And you should also give the opinion regarding the nature of injuries, whether they are simple or grievous. You know about the various grievous injuries. As per section 320 IPC, you know, permanent disfiguration of face, loss of vision, loss of hearing in one or both sides, fracture of a bone, right? Fracture of a bone, any injury which endangers the life of the individual, impotency or emasculation, causing impotency or emasculation of the individual, any injury which entails the person for 20 days, continuous admission for 20 days, so as to prevent him from carrying out his natural work. So the various things we have studied, grievous injuries. So you have to give your opinion. Suppose you have taken x-rays, you are not very sure whether there is a fracture or not, then you have to reserve your opinion. But it is only the same casualty medical officer who has started the thing has to give the final opinion. And please remember, whether there are 10 injuries, there is a skull fracture, there is a forearm bone fracture, there is a femur fracture, and there is also a phalanx fracture, the loss of the tooth. Everything is only one grievous injury, right? Even if there is loss of only one tooth, a fracture of a tooth, or the loss of a fracture of a phalanx, that also grievous injury. There is nothing like grievously grievous injury and simple grievous injury. There is nothing like that, only grievous injury, right? So this accident register should be filled in triplicate. filled in triplicate. The original and duplicate to be given to the police, and the third copy retained in the office for future use. Third copy retained in the office for future use. This is very important because you will be called to the court to depose. At that time, you can't go to the court without a record, and you can't ask the court, please give me those papers and let me read from it. Because your signature has to be verified, and you will have to say this, yes, this is my signature. I have prepared the certificate. So you will read it from the third copy. This is also important. And yet another very important thing I want to say is accident register, the filling up, especially when the patient is conscious, oriented, and he is answering your questions correctly. There is a method of filling. You should not write except the patient's name and brought by whom. You should not write in the history side. You should not write so-and-so has assaulted him, alleged to have been assaulted by Ramsamy. All those things, please do not write. You have to simply write alleged to have been assaulted by a known individual. That's all. Alleged to have been assaulted by a known individual. Please do not write the names, even if the patient says that I was hit by so-and-so, so-and-so, so-and-so. No, it is not our job. It is a duty of the police. Police have to meet that guy, they will have to take, and then they will have to take it. I still very vividly remember, again, in Raipeta Hospital, where we cater to a very important section of the Madras city. One Sunday afternoon, the casualty medical officer called me. He told me, sir, here a person has come. He said he was beaten by so-and-so with the sticks and chappals, two individuals with sticks and chappals, and he has got injuries. What should I write? I said, why? What is the problem? No, sir, he is telling the names. He is insisting that the name should be written. I said, you are the casualty medical officer. You are not supposed to take the guidance from the patient. So, enna sir, alleged to have been assaulted by two known individuals. Venanna our female solradanaala two female individuals, two female persons. Adukku mele edhum ezhudadinga. That time, one of the authority in the hospital, he has got a particular political leaning. So he was pressurizing the casualty medical. Ninga per ezhudunga doctor. Then he called me again, sir, avar appadi solrar. I said, no, don't write. Tomorrow when I meet him in the hospital, I will tell him why it should not be written. Tomorrow, next day, that man was very angry. He asked me, enna sir, neenga venanu sollitingalame? Ella mele indi kekranga. The government lende. The government people, the ministers are asking why the name has not been written. Then I told him, sir, you can write the name, but the case is not going to come tomorrow or today for the court. It is going to come after jolly well, after 6 months, 1 year, 2 years. You know the things that are happening in our country. Cases take years together. Even though we very proudly say justice delayed is justice denied, but that is the practical thing that's happening. So even assuming that after 6 months this case comes to the court, by the time a compromise has been reached between these two individuals, the assaulted person and the victim, compromise takes place. Then that fellow will be asked in the court by the defense lawyer. Defense lawyer is for the accused. He'll ask, doctor per sonniya? Illiye, na yar peru sollave illiye. That fellow will very coolly say, because his hands have been greased nicely with a lot of apologies. Right? And people will simply completely change the thing. Then who will have eggs on his face? The doctor, poor doctor. உங்களுக்கு என்ன டாக்டர் கோவம் அவங்க பேர்கள் எல்லாம் ஏன் அவங்க பேர் எழுதினீங்கன்னு ரொம்ப கூசாம கேட்பான். இல்லையா அவன் தான் சொன்னான். No, 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 no. You have heard his evidence now. He is telling that I haven't told. So that is why you are not to write. Alleged to have been assaulted by known individuals. என்னன்னா இந்த கேஸ்ல 2 female persons போட்டுக்காங்க. But don't write. Then of course he was not convinced because he is politically motivated, so he was not convinced. நல்ல சான்ஸ் சார் உங்களால போச்சு சார் பரவாயில்ல, it's okay. So this is one very important thing about accidents, sir, because that's why I told you first case Pondicherry, the fellow says something and the next day he changes. Next day the whole village came. Sir, ஏழை பையன் சார், அவன் அடிச்சிட்டு போயிட்டான் சார். No, we are not to do any such thing, right? Similarly, in this case, he gives the names of the individuals, but don't write. Don't write. You simply write alleged to have been assaulted by a known individual. Finish. There ends the matter. Then you are going to describe the injuries and then the treatment, then the investigations required, and in case he requires an admission in the hospital, you admit him. There ends your matter, and you write the accident register, fill it up, and write your opinion. The injuries described are grievous in nature or simple in nature. Hand over the original and duplicate to the police, and retain the third copy. There ends the matter with regard to accident register. One more job for the doctor is recording the dying declaration. Dying declaration is what? It is the statement made by a person in his deathbed or made by a person under expectation of death, describing the circumstances that lead to his present stage. Please understand, dying declaration is not a statement made by a person in his deathbed that I got property like this, I got so many people. All these things are not dying declaration. Dying declaration is statement made by a person in his deathbed describing the circumstances that lead to his present condition. So I was coming in the car, somebody waved their hands and stopped the car. When I stopped the car, they came near me and then started punching me on my face. They dragged me out of the car, hit me. That is dying declaration. Usually, dying declaration is done by a judicial magistrate. Doctor has to inform. Say, as soon as you get a patient in the casualty, once you see the case, you have to inform the police that sometimes police themselves may bring the case. Then you are going to examine the individual. You are going to say, patient condition nalla illa, he may kick the bucket. So any legal formality irundha mudichukanga sollita, they will arrange for the police to come. They will arrange for the magistrate to come. In case the magistrate cannot come, or he is out of station, or he is ill, or even before the magistrate comes, this guy may croak, whatever can happen. In that case, the doctor himself can record the dying declaration. What is the thing? You have to record it in front of 2 neutral witnesses. Who are the neutral witnesses? Somebody working in our casualty, some staff nurse, or some other patient attender, or somebody with a definite address so that you can call them at the later stage. But one very important thing when you are recording the dying declaration is the police should not be there. The police should not be there. If the police is there, the dying declaration is going to be vitiated. Right? So, court la romba innocent they will ask, dying declaration neenga da record panningala doctor? அப்ப அந்த இன்ஸ்பெக்டர் இருந்தாரா இல்ல எஸ்ஐ இருந்தாரா அப்படிமா. We should say, we should wake up from our slumber. No police fellow was allowed inside the casualty. Nobody was there. அப்படின்னு நம்ம கவுண்டா சொன்னாதான் that fellow will realize, oh, this guy knows something. நம்ம பாட்டுக்கு ரொம்ப வீக்கா இல்ல இன்ஸ்பெக்டர் இல்ல சப் இன்ஸ்பெக்டர் இல்ல ஹெட் கான்ஸ்டபிள் இருந்தாருன்னு சொல்லிட்டோம்னா the dying declaration is ineffective, right? So again, for the dying declaration, whether it is going to be recorded by the magistrate or by the doctor, we should certify the patient is conscious and oriented, compasmentous, conscious oriented. எப்படி கேட்க போறோம்? We are going to ask some small simple questions. எங்க உங்க அட்ரஸ் என்ன, என்ன வேலை பார்க்குறீங்க, என்ன ஏஜ், எத்தனை பசங்க இருக்காங்க, என்ன சாப்பிட்டீங்க, finish, right? So compasmentous. Once you record the dying declaration, you sign, and then 2 witnesses also will sign. Then you put it in a sealed envelope and send it to the court, right? This is the thing expected of you in the recording of a dying declaration. So I told you all these important things what you have to follow in the casualty, that the various things we have to do, including filling up the accident register, intimating the police, and examination of the various wounds and giving the opinion as the grievous hurt or a simple wound, also the dying declaration, and what to write and what not to write in the accident register. All these things we have mentioned. So this is the basis of our examination in the casualty. So this is pertaining to the injury cases, right? And what is the next thing? You can get this case also, child abuse. This is becoming quite rampant, especially with the female feticide and other things that is happening. Child abuse is another thing which is you can see in the casualty. I remember way back in the mid-90s, 2 children were taken to the Children's Hospital, Egmore, where a very diligent pediatrician saw those cases and he opined, he made it a MLC. He made it a MLC because the mother brought the cases. பையன் விழுந்துட்டான், அடிபட்டுச்சு அப்படின்னு சொல்லும்போது he saw those cases, examined it scrupulously, and he sensed there is something fishy in this case, and he has informed the police. And within another 3 or 4 days, another boy was also brought, stating that he is the elder brother of that child. Then he called the police and handed over the woman. On police interrogation, subsequently it turned out that the mother, she had some problem with the husband, so he wanted to dispose of these children. With the result, she started beating the children, abusing them, putting them that burns and this thing, all those things. So with the result, battered baby syndrome. I think first registered, recorded battered baby syndrome in Chennai was in that case. I remember that. If a child is brought with multiple injuries and deformities of varying ages, it's suggestive of repeated physical assaults on the child. If you take an X-ray, you can see that the rosary beads appearance of the ribs, and after following the routine protocol, the police should be informed as it is a cognizable offense, right? Cognizable offense is that police can even arrest the individual without a warrant. That is cognizable offense. Then next is, yes, this is other important case which come to the casualty, especially government hospital casualty in these days, right? But once upon a time, those days there were there was prohibition there, no TASMAC and other things. So police were very actively pursuing these cases. Nowadays, incidence has come down slightly, that's all. But drunkenness cases need not be filled in the accident register, except there are injuries on a body. Police catches hold of somebody in connection with a crime and they are beating him. Then you have to fill up the AR and probably you will have to write the person breath smells of alcohol. That also you will have to mention. But one very important thing in drunkenness case, police brings a fellow stating that he was driving in reckless speed under the influence of liquor and he has hit against somebody crossing the road. So please examine him and issue a drunkenness certificate and you give the specimen, blood and urine, to be sent to the forensic science lab for a quantitative examination. But this fellow can refuse to give the samples. You cannot force him. In drunkenness cases, the guy can refuse to park. Alam kudukka mudiyadhu sir. Vena sir, enakku thevilla sir. Appa what is your role? You will have to tell him, yo, நீ கொடுக்க முடியாதுன்னு சொல்றத நான் அப்படியே எழுதிடுவேன். அப்படியே எழுதிட்டேன்னா கோர்ட்டில் டுமாரோ இட் வில் பி யூஸ்ட் அகேன்ஸ்ட் யூ. அதுக்கு உனக்கு சம்மதமா? பரவாயில்ல சார், நான் பார்த்துக்கிறேன் சார் அப்படின்னுடுவான். சொல்லிட்டான்னா then we cannot do anything and that you have to write it in the accident register. Patient refuses to part with the samples. Patient refuses examination. He was explaining the consequences of that this particular thing may be used against him as an evidence at a later date in the court. Even then the patient says, go ahead, I cannot give. So we have to say, tell the police, இல்லப்பா எடுக்க முடியாது, அவன் வேண மாட்டேன்னு சொல்றான் அந்த ஆளு, எங்களால ஒன்றும் பண்ண முடியாது. We will have to tell. We have no other go but to this thing. அதுக்கு மேல ஃபோர்ஸ் பண்ணி எடுக்க கூடாது. Except there is a condition, section 53(1) CRPC ஒரு condition இருக்கு, where the police feels the forcible examination of the individual will yield to the positive commission of an offense னு சொல்லி ஒரு செக்ஷன் இருக்கு 53(1) CRPC. அதுல மட்டும் ஃபோர்ஸ் பண்ணி அவனை 4 தட்டி எடுக்கிறதுனா எடுக்கலாம். அதெல்லாம் போலீஸ் பார்த்துக்கணும், நம்ம பண்ண முடியாது. We cannot do all those things. In the clinical examination, if we are going to examine, you are going to give only 3 types of opinion. Enna? You are going to examine him clinically. Drunkenness case எப்படி examine பண்றதுன்னு சொல்லி கொடுத்திருக்கோம். Walking in a straight line test, buttoning and unbuttoning, and then his way of speaking, slurred speech, and his memory power. So all these things will be taken into account and you are going to examine him. If he is not able to do anything properly, you are going to say, and breath smells of alcohol. That is very important. That you have to write, breath smells of alcohol. And you are going to say, he has consumed alcohol and he is under the influence of alcohol. He has consumed alcohol and he is under its influence. And you are going to send his blood for analysis. Suppose it's going to come as 200 milligrams percent or more than 150, 200, 250 milligrams percent, then it is definitely not permissible. But other category is he is able to do every test, whatever you want. He wants to walk in a straight line, he walks. He is able to do the buttoning, unbuttoning. He is passing the thread through a needle. Everything he is able to do, but his breath smells of alcohol. So what you are going to give? He has consumed alcohol, but is not under its influence. That is the opinion you will give. And probably his blood level may be about 100 milligrams percent or less than 150 milligrams percent. And third opinion is he has not consumed alcohol. He has not consumed alcohol. So these are the things that are important in drunkenness. But nowadays, I think the cases have come down a lot. And other thing which comes to the hospital practice is sexual offense cases. Sexual offense cases usually don't come to casualty, except at odd hours, very small child, sexually assaulted in a very critical stage. That type of cases come to the casualty. Then we will have to examine that case, and without wasting time, probably I have seen one child, a 4-year-old girl, completely, there was a gross perineal tear and this thing and all. And we immediately referred the case to Children's Hospital, IGMOR, where the child underwent a lot of surgery and subsequently the child. But initial certificate was given by the doctor here, and subsequently the court convicted those guys also. They were all given some 10 years imprisonment. One fellow was convicted to life. So that type of a thing. But sexual offense cases, usually the magistrate gives the requisition. Sometimes police, majority of the time, magistrate gives a requisition for the examination of the victim and the accused. The most important thing you must remember is the victim should be examined only by a female doctor. As far as this state is concerned, no male doctor can examine. You may ask me, sir, even in our college, the male doctor has taken charge as assistant professor in OBG department. What will he do? He can examine by virtue of his qualification, but he will keep a staff nurse, female staff nurse by his side, and probably the mother or sister or some female relative of the woman, ask them to stand on the head side of the patient, and then only in their presence he should commence the exam, finish it, then take their signature also. In the பெண்ணை பரிசோதனை செய்யும் போது நான் உடன் இருந்தேன் அப்படின்னு சொல்லி ஒரு ஸ்டேட்மெண்ட் வாங்கிக்கணும். Then only it is safe. Otherwise, the defense lawyer can take us to task. So that is another very important thing. Then accused will be examined in the forensic medicine department. The male doctor will examine, and you don't require any sort of, police will ask all the rubbish things, right? College assessment, all those things. No, don't do all those things, right? And if you want, you can take the blood sample, send it for grouping, right? Or if the girl alleges that she is pregnant because of this fellow's relationship, probably you will send them for the DNA fingerprinting, which is also done in the State Forensic Science Laboratory. But for that, we will wait till she delivers the baby, right? Then the putative father, the mother, and the baby will be subjected to a DNA examination, and that case will be subsequently decided in the court after the DNA result, right? So this is the thing about sexual offences cases. But again, the chances of cases coming to private setup probably may not be much, but government hospitals, even today we get cases. We are reading in the newspapers. Even last month we have seen in near Trichy, near Pudukottai, young girls of 13, 14 years are all being sexually assaulted, abused, and then subsequently they were murdered also by burns or something like that. So I think we got a role to play in these things, even though the Sexual Offences Act has been changed. The act has been made more strict. Originally, it was only the Sexual Act. Now, even putting a finger or a pencil in somebody's mouth with the intention of something, that is also comes under that thing. So, still things are happening because probably people, the message has not gone to the people correctly. And person brought dead to the casualty. So far we have been discussing about persons who are brought alive to the casualty, how you have to deal with. Person brought dead to the casualty, you make an AR entry, but avoid describing the injuries in the casualty in a brought dead case, right? Avoid describing the injuries, because a forensic medicine fellow, body sent for our postmortem, he is having all the time in the world to look at the body from top to bottom, front and back, everything he can write. But it may not be the case with the casualty medical officer. Multiple cases will be there, screaming, whining. So your job is to safeguard the life of those people. So what you can simply write, you make the entry, so and so. You can even ask one house surgeon to make the entry, and then, but of course, while signing, please read everything and then only sign. Otherwise, house surgeon would have written something also. So you make the entry and then you say body is sent to mortuary, right? Pulse query, BP query, heart sounds not heard, breathing sounds not heard, pupil fixed, dilated. Only thing you can do is whether rigor mortis has set in. You try to flex the hand, you try to lower the lower jaw, and see whether rigor mortis has set in. If there is rigor mortis, you write, it's set in the face, it's set in the upper limbs, lower limbs are very free, not yet set in, right? And body temperature, you can record it, body cool, warm, all those things. And hypostasis is another, the postmortem discoloration. You will see in the back whether it has started appearing, whether it has settled down. Because it's all helpful in determining the time since death or the postmortem interval. So for that it is useful. Even if you are not mentioning it, it's okay. But you don't write few injuries, because the postmortem fellow will be writing about 20 injuries. You would have written only 3 injuries. The defense lawyer will try to make that, and the public prosecutor will be, he will be very annoyed with you. Enna doctor paakuringa neenga, enna doctor work panneenga, ipdi illa namba work pannadha pathi he will start commenting. Adanalada it's a good practice not to note down the injuries in the casualty. Right. This is the way you are going to handle the things in the casualty, right? So I hope I have not omitted anything. In case you are having any doubts, you can put forth your question. I will try to answer your questions. Then medical ethics. This is one very, 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 very important topic pertaining to the medical profession today, because somehow the medical profession, which was supposed to be a very noble profession, doctors are next to God, demigods, all these things, by the proliferation and expansion in this visual media, in the form of Google and all those things, medical profession is being downgraded to a business. The medical profession is brought under the Consumer Protection Act 1986. It was established, it was brought as a legislation in the country in 1986. 1995, medical profession is also thrust in this Consumer Protection Act. Legal profession is not involved. Medical profession is involved, right? So with the result, the doctors nowadays, instead of seeing the patient, have to look over the window to see whether anybody else is waiting to file a case with the camera on to shoot our actions. That is the situation today. Gradually, I think they are taking more and more of the thing. Even about 15 days back, the National Consumer Disputes Redressal Commission, NCTRC, in Chandigarh has given a judgment for unfair trade practices. They charged the hospital 10 lakh rupees to be paid to this. No negligence have been proved. No negligence have been proved, right? On the part of the hospital. The customer has not got into any fresh difficulty or anything. Still, a case has been filed against the doctor, and the court has decided that it is an example of unfair trade practices. So they fined 10 lakh rupees for that hospital. You know what is the mistake they have committed? They have taken the consent in a pre-printed format. They have taken the consent in a pre-printed format with few spaces left blank. They said it's an unfair trade practice. My God, in a way, I thought probably we are all in the passing stage of our last quarter of our life. We are not going to see this anymore, but my heart aches. But the two members who have given the punishment, of course, this can be contested in the Supreme Court by the hospital. That's a different story, but unnecessary headache. Out of the two members, judicial members, both of them are not from the judiciary. Judiciary means existing serving judges or retired judges of High Court, Supreme Court. No. One person is a doctor. He is a pathologist. He was a professor of pathology. And also he has done law. He has done a PhD in law. He is one of the members. They have passed the rule. How to avoid all these things? That we are going to now say how to avoid those things. That we are going to see in medical ethics. That is why it is going to be very, very important. The violation of medical ethics constitutes the professional misconduct or the infamous conduct, right? The famous 6 A's and an umpteen number of things. Abortion, adultery, alcohol, addiction, advertising, association with unqualified persons, all these things are the crux of infamous conduct. They are the crux, they form the crux. But there are yet another so many things, right? Including dichotomy and all. But in these cases cannot be brought in a court. Inquiry and punishment by the State Medical Council. If you are not happy with the State Medical Council decision, you can appeal to the Indian Medical Council. That's all. So this is about medical ethics. This is the most important part in our medical practice involving the patient, consent. Many a time we take the patients for granted. You know, because it's a noble profession. We are next to gods. We are all demigods. Until such time we give our bill, we will be worshipped. The moment we give the bill, we will become their enemies. That's the other side of it. But many a time, the lacunae is on our part. We are not following this important thing called consent. Consent means voluntary agreement, compliance, or permission. It may be an implied consent or an express consent, two types. Implied is when a patient comes to you, you are going to examine the patient, you are going to record the pulse, you are going to keep your stethoscope and you are going to hear the heart and breathing sounds, and you are going to do some percussion. All these things, implied consent. If a person goes and complains that this doctor has examined me without my permission and all, then the simple question that can be asked to the patient is, where did he examine you? In his clinic. Where is your house? This place. What is the distance between your house and the clinic? 2 kilometers. Then you have gone on your own. The doctor has not invited you. The doctor has not given a pamphlet to please come and visit me and all. You have gone on your own for your this thing. And why should you go to your doctor's house? Without getting examined, why should you go to the doctor's house? So your case is dismissed. So that is the implied consent. Express consent. Patient comes to you with abdominal pain, you are examining the patient and you are suspecting a probable appendicitis. You are telling the patient, "Arey, you are probably suffering from appendicitis, you may require surgery. So you go and get admitted in this nursing home, or you go and this thing." Who is going to operate? I am going to operate because I am a surgeon. And fine. For that, I cannot simply make the patient lie down in the operation table couch and I can't cut open the abdomen. No. I have to take a consent. What type of consent? Maybe a written consent or a oral consent or a written consent. But oral consent can always, they can say no. They will deny. That is why you have to have a written consent. What type of written consent? Court will accept mainly a written consent because written consent as the form of permanency is there. And you can prove also things easily, right? But what are the things the consent should? Munnalla, previous days, the thing that was in existence was, I agree for my son to get operated under anesthesia. The father will sign. This is what is called as a blanket consent. It has absolutely no value in the court. So what should be the composition of this consent? The doctor must inform the patient about the diagnosis. What is the nature of treatment or what procedure he is going to do? What is the risks involved, including future? He may get we will definitely remove the appendix, nothing will happen. But in the immediate post-operative period, he may go in for an infection, which is probably beyond our control, for which also we will give antibiotics and all, still something can happen. Then what is the prospect of success? I have removed the appendix, henceforth, no more chance of getting appendix in his lifetime because there is only one appendix, right? So he cannot say that he had another extra appendix, accessory appendix, all those things. No, it is that prospects of success. Prognosis, if the procedure is not performed, if it is not going to be performed, it may go into a bursting of the appendix. Appendix may burst and then fulminant infection, peritonitis may happen, which may lead to the death of the patient. What is the alternative method? So if there is any, you can tell. Otherwise, probably no. To my knowledge, there is no other alternative treatment. And what is the likely cost of the treatment? This is also very, very important. You have to tell it is going to cost you about 25,000-30,000 rupees. The minimum surgical charge will be this much. Over and above, other things are there. If you are in a special ward, proportionately things will go up. That type of clear-cut thing should be there, and you will have to fill up all the columns. No columns should be left blank, because fearing that latest judgment, we cannot start writing things. Printed format is right, accepted, but you have to write. See, for example, nowadays people are doing laparoscopic surgeries, buttonhole surgeries. And in that, you have to give a declaration of like, we will do a buttonhole surgery or the minimally invasive surgery with the least scar. But there is a possibility, because of some unforeseen condition complication, it may have to be converted to a open surgery. That line should be written clearly and the patient should be made to understand that and he should sign. Otherwise, what happens? You say the patient, yeah, I will do a buttonhole surgery. You then try to go through the thing, extensive additions inside. You cannot proceed. So you convert it into open surgery. Tomorrow that fellow will say, I was about to participate in the world, this competition or some competition. I never wanted a scar, but this doctor has inflicted a scar on me and my future career is doomed. So he has to pay me so many lakh of rupees, right? So everything you make it, that is the informed consent. You don't keep the patient in the dark. See, when a lot of litigation cases were coming, a work was done in Nellore, Sri Krishna Medical College, by Dr. One forensic professor B.V. Subramaniam. He has conducted a survey among 200 odd people who have sued against the doctors. He went and individually talked to all the people, and that paper was a very nice accepted paper. He presented it and it came in a journal also. So out of the 200 people, why they have gone to the court? Only about 18 people said because the results of the treatment is not up to our expectation or what the doctor has promised. There was failure in the treatment. Rest of the nearly 150 people stated that the doctor was not talking to us properly. Not properly. He was not communicating with us properly. Everything he will just, he will, like an express, he will tell, he will never bother to take our opinion because of the lack of communication, the lack of expressive thing. We decided to go to the court. So that is why it is very, very important you establish a contact line with them. Keep a cordial relation with them. Keep with them. That I think the students have to develop while your students house surgeons. You will have to develop that habit of the talking, conversational style, and develop that cordial ambience. Then the faith in you becomes more and more on the mind of the patient. So even if something goes wrong, otherwise, things will happen like this. So please develop that habit. Okay. So the above details should be written and signed by both the patient and the doctor. That is important. You have made him understood whatever you have written. Of course, in extreme emergencies, consent can be waived and treatment proceeded after informing the higher official. Suppose a person comes in a very dreadful condition, he requires an immediate surgery, nobody there, no relatives there can sign. He is not in a position to sign himself, even if he has crossed the age of 14 years or 16 years. He is not in a position to sign, no relatives, nothing. We have to do, what will we do? We will inform the medical superintendent. Sir, in the matter of emergency case, we have to take him up for surgery. We are taking him up. Medical superintendent will sign. So, for a hostel student, parents cannot come. Then the dean can sign for an emergency treatment, loco parentis, that's called. So, that is the thing with the higher officials' permission, respondent superior. So, they will give the permission, we can go ahead. Examination of the patient without consent is illegal. It is trespassing. So, for which a criminal action can be taken against you. Then professional negligence, you know, it's a omission to do something which a reasonable man would do, act of omission. Failure to give TT in a case of injury, right? Simple. Or doing something which a reasonable man would not do, act of commission. Patient solitaire, sir, na pencil in allergy, you still inject a penicillin and give him an anaphylaxis, he dies, act of commission. Then types are civil medical negligence and criminal medical negligence. Criminal medical negligence is 304A, rash and negligent act. Usually, whenever a patient dies, that is what the police tries to do. And civil negligence cases, only monetary compensation. And cases dealt with by the consumer courts are only civil in nature. In criminal negligence cases, police books under 304A IPC and charge sheet in the criminal courts. Both fine and imprisonment. Civil negligence cases only fine. Imprisonment kadiyad. Infamous conduct only by the medical council. Civil negligence case, and criminal negligence case. Civil negligence case, civil courts alone will determine. Consumer cases fall under that category. Only monetary fine. But criminal negligence case, both imprisonment and fine can be given. And what are the lines of defense? Suppose case file pantanga, enna pandrathu? And in negligence cases, following are the lines of defense. One the infirmities in the implied contract, right? Patient na inda mari da sonne ana he has understood it wrongly. Then error of judgment, right? Misadventure, risk of inevitable accident, contributory negligence, res judicata, limitation. Res judicata na the case has already been decided in a previous court. திருப்பி அந்த கோர்ட்ல இவனுக்கு போதுமான ஜட்மெண்ட் கிடைக்கலன்னு he cannot bring another new suit in a different court, right? And limitation is within 3 years of the damage he has filed a case. Beyond 3 years he can't file a case. 3 years back or 4 years back I had this and this has resulted in this. If it crosses 3 years, but still these are all not hard and fast, because courts always have, they take a very, different view. Ayyo Pavan, he is an uneducated person, he is from a village, and all those things can happen. Of course, what is contributed, patient also contributes, risk of inevitable accident, and all these things are the lines of defense for the doctor. So, based on this, we will try to do the thing. Then, this is about the various things I wanted to tell for those young doctors who are going to start your practice or who have already started the practice. For only thing, present day, the situation is not all that good, but we need not be pessimistic, we need not be despondent. What is required is a good communication skill. Straightforwardness, the honesty, right? That's very important. And if we practice all those things with a human touch, I think we are going to be successful. We will definitely succeed. But remember those basic things, the ethical things, and never forget the consent part. Consent, do it properly, right? And as far as possible, keep the records properly. Keep the records. Don't do anything without any records. And then I think we need not worry about our profession. And anyway, people like us are there to help you out, advise you also, right? So I think I'll stop at this, because I actually wanted to explain cases also, some of the cases in which I try to help our clinical colleagues, how with my argumentative skill, how I could take out. But I think the time is running short. I am left with another only 15 minutes. So probably I'll reserve it for the questions. And right, Raghunandan.
Thank you, sir. Thank you so much. So today we got few questions, especially first one is, what kind of ethical issues can a doctor returning from abroad with Indian UG degree and foreign PG degree expect, especially in UK, from UK?
See, the degrees part, I think the Indian government has now, we have to make an application to the Medical Council of India, and Medical Council of India has to take a final decision on the PG qualifications obtained from UK, like MRCP, FRCS, etc. Right? So you can start a practice. You can start a practice in a private nursing home and all. But for a government service, if you say I am an FRCS, I am equivalent to an MS, or an MRCP equivalent to an MD, so I also should be getting the promotion, I should be promoted, may not happen. It is the MCA who has to take a decision. Suppose a person with MS goes there and does, he is doing a FRCS, Edinburgh and Glasgow, and then he comes back, he joins the government service. He will get the promotion not based on his FRCS but on his MS. But for him to practice, I think it's no bar. It is they can still continue their practice. Okay.
Thank you, sir. The next one is, in context to the COVID pandemic, what we have to write in the accident register where we cannot check the breath smells, like in case of drunkenness examination.
Pardon me, repeat the question.
So in drunkenness examination, we usually do breath smell, urea breath test. So in this case, due to COVID-19, we could not take the breath test. And in that case, what will be the other alternative for the casualty medical officer?
See, we have got a breathalyzer. We got a breathalyzer is an equipment. And an alcoholic smell, he need not blow on your face. It is impervious. When he enters the room itself, we can make out. So the doctor, if I am sitting like this, you can ask him to blow in the opposite direction. You ask him to blow this way. Even then you can make out the smell, right? And breathalyzer, the police fellows or even hospitals may be having, we can ask him to blow it in the breathalyzer. Then we will have to sanitize it. That's all. We have to sanitize the machine, and probably we will have to use it for the other guy.
Thank you, sir. The next question is, what is your opinion on burying the COVID-19 dead bodies in plastic? Because plastic takes long time to decay. The body inside the plastic may not decay so fast. So what will be the other alternative we can do? Asked by Dr. Sukumar, sir.
I am in fact very, very sorry about the present decision by our ICMR and all. Because when we say when a person dies, his circulation stops. And I don't think any worthwhile study has been done to state that the body, the virus spreads from a dead body to other people, right? This type of removal of the bodies by the corporation without an autopsy was done in case of those days, in case of rabies. Subsequently, HIV came, HIV infections. When it came, we were informed that's a case of HIV under treatment or had treatment. Only for those cases, we used to have the gum boots, double layer of gloves, then the face shield, a mask, face shield, cap, and a cotton apron, over that a plastic apron with a double layer of gloves. This is the precaution we had for HIV. But I do not know why this type of thing. I have even written to the ICMR, please allow some limited autopsies. And if the bodies are going to be cremated, and I don't think what is the risk involved for the society. Only for, I think, Dr. Sukumar, I think my friend microbiologist has to explain whether the COVID-19 virus is so much, can withstand that high temperatures of several 100 degrees centigrade, 800 degrees centigrade in a burning furnace. But I don't know why people are, I am still expecting a reply for my letter from I wanted at least some cases, at least if not non-medical COVID-19 death, probably they say no, it cannot be done. At least for those MLC cases, we should, they are being done, autopsy is being done. But because of the fear complex that is being raised, I am afraid whether a proper autopsy is being done, whether bodies are just handed over without any autopsy. I do not know what is happening. But what Sukumar sir says is very absolutely right. The bodies are kept in a plastic bag. But only thing I in fact talked to one corporation guy. He said, "Pannandadi pit, sir, Pannandadi pit," as if I don't know. Honestly, I do not know the answer for this. Why this is being done, and I'm not very sure on this.
Thank you, sir. And for next question is, so when a person is getting a RTA, road traffic accident, and he is not hit by some other person, but he himself hit on some object or electric pole or something, will that be registered as MLC or non-MLC?
Any case comes as an accident to the casualty, please register it as an MLC, because the government gives a lot of concessions or help to the people. For example, if a person dies of a snake bite, the government gives some 25 or 50,000 rupees. We have to, for that he should have a postmortem certificate. He should have a postmortem certificate. Similarly, if the construction worker falls from height, then he is given some 1 lakh rupees as compensation by the government, for which he should have a postmortem certificate. Similarly, the person goes and hits against the vehicle or a lamppost or the central meridian while going in a vehicle. If he is having an insurance, that insurance will be given only if he is having a postmortem certificate, a postmortem done and the cause of death is given. Only then it will be given. Otherwise, the family stands to lose. With the person's death, that's all. One chapter is over. But the family is there to carry on further. They require money. At least these type of things will be available only if a postmortem is done. Without a postmortem, they will not give. I have seen that government refusing these things. The tahsildars, they are the ultimate deciding authorities and passing all these things. They will, sir, postmortem, sir, that is the reply they give. So that is the thing. I think it is better to do a MLC.
Thank you, sir. The next question is, so why the for individuals who is having drug abuse, who are suffering from drug abuse, can the doctors intimate the police in such case, or it will be a break of confidentiality?
See, this is where it comes under privileged communication. We got a professional secrecy and a privileged communication. If this drug addict is going to pose a lot of danger to the society, if the doctor feels this person, first your job is to try to tell him, give him advice. If necessary, refer him to a psychiatrist, give him enough counseling. Even then, he is not changing his path. He continues to do the same thing. And you can definitely inform the authorities that he is addicted to this drug, and in spite of all the best measures, I am not able to bring him back to the normal society. So I am bringing it to your notice because he is likely to pose a danger to the society. Or if he is going to get married, you can even inform the prospective groom or that bride's place also that this fellow is a drug addict. That comes under privileged communication. So no question of violation of a professional secrecy. You are safeguarded. But whole thing should be recorded. There should be a written proof for all these things, right? And without a written proof, I think we are in a soup. And with proper writing, with creation of proper record, we are safe.
Thank you, sir. Next question is, if a person is having, if a person or victim is coming with sexual assault or POSCO case without informing the police, what is the duty of a casualty medical officer? Can he do a medico-legal examination without police requisition?
Victim, for the victim.
For the victim.
If the victim comes directly to the casualty with the history, and if she requires a medical attention immediately, a gynecology, a OBG person can be called, a female doctor can be called, and the necessary treatment can be given. You can make an accident register, but it is your duty to inform the police immediately. This person has come directly to the hospital, considering her health condition. In order to render the first aid, in order to give the treatment, we have started treating her. But these are all the things. So please come and take over the case. Then the police will come, then question that individual, then they prepare the records, go to a magistrate, and then they will proceed further. So we cannot turn back a person. Suppose it is like this, you imagine a condition where a person says, I have been, sexually assaulted by so-and-so about 1 month back, or for the past 6 months on a regular basis, and now he is refusing to take care of me. I want to file a case. That type of a case comes, then you need not register the case. You ask the person to go to the police, make a complaint, and then let the police bring the case to us, right? If the health is not endangered, person is hale and healthy, safe, the only motive there is to punish somebody, then we are not going to be a party to that. You will say, first go to the police, register a complaint, then come back through the police, we will examine you and give a certificate. That is our justice. And another very important thing, you please remember, this cases, the rape, we should never use the term rape. Rape is not a medical diagnosis. It is a legal diagnosis, right? It is for the court to decide whether the person has undergone rape or something. It is not our job. Please remember that. We should never write that so-and-so has been raped. That we should not do, right?
Thank you, sir. So we got a question from Dr. Sendil Kumar. As a surgeon, once I got a female child patient in OP with trauma to external genitalia, allegedly by injury by a toy as said by parents. But I suspected child abuse. Can we intimate police with suspicion alone?
See, this is a slightly difficult situation. If the child is brought by the mother and the mother gives such a history, then probably if you are sure that it is not the way in which the mother alleges, you feel it's slightly a different type of thing, you tell the police, intimate the police, but I am sure police will again interrogate the mother, and mother will again repeat it for her own reason, because some of her close relative or the grandfather or somebody may be the culprit, and without realizing what to do, the mother may be repeating the same story to the police. Police may not be very keen on proceeding with the case. But if this is going to be a repetitive affair, if the mother brings the child again and again, I think you can straight away make it as a AR entry and then intimate the police, in which you can very specifically write also, the records available with us show clearly that this patient is brought by the same individual for the third or the fourth time with extragenital or genital injuries. That type of thing can be given and made it, we can make the police act on this. But for the first time, I think it is very difficult. We have to say, because we can't expect a person other than the mother to be the custodian, better custodian other than the mother. So that may be a bit difficult in the practical day-to-day life.
Thank you, sir. And Dr. Suguma sir wanted to add just one point before concluding the session. So according to him, as you asked him his opinion, he just want to mention here that virus cannot multiply in the dead body. So according to him, the best method for disposal of dead body is by incineration. What is the comment about it? He just asked you a comment.
That is absolutely right, Dr. Sukumar. Probably, I think we can again, both of us can together, including some pathologists also, will take into our fold and we all can write to the ICMR. Please have a rethink about the whole thing, and please give newer guidelines, because the present one, I think, is creating a lot of problem for so many people, and there is absolutely no scientific progress. No scientific progress. Everything is almost in a thing with the loss of life of so many healthcare workers, first line workers, including more than 100 doctors. I think it is posing a real danger. I think we can again put forth our points and write to the ICMR.
Thank you, sir. The last question is, if printed consent is not valid, should the written consent be obtained in all routine elective cases also? Like, because more than 95% of consents which we are obtaining is a printed consent. So is it valid, or what else we can do? What is the other alternative?
The latest case which I told is printed consent form with some of the blank spaces not getting filled up, not filled up. That is what they have pointed out. That pathologist Karthikeyan, Dr. Karthikeyan had pointed out. It is not filled up. It's a very mechanical way of getting the consent. So it is not a real informed consent. But what I am telling you, if you start writing handwritten consent means for a very busy hospital, I think half the time will be lost in only writing. So printed consent forms are not a taboo. It is right. But what I am suggesting is, don't leave any column blank. And before the signature, suppose in one page, the printed consent form occupies this half or something, the signature part, patient signature, doctor signature. In between, you give some space so that you can write another, add 5 or 6 lines in your handwriting. In your handwriting, you can have some lines added. You handwrite certain essential things which have been omitted in the printed format, and write all those things which are relevant to that particular case. You write and then you get the signature. I think this problem can be solved. So printed consent form is not a taboo. Only thing, not filling up the printed form correctly is the problem here.
Thank you so much, sir, for your words of wisdom. That concludes a remarkable, memorable, and knowledgeable event. We hope that the students gain knowledge on medical legal aspects in clinical practice. I promise you all that by the end of today's session, you would have gained a lot of knowledge, and this will be a new beginning, and this is going to travel with you throughout your profession. Thank you so much, sir, for taking your valuable time and teaching our students. Thank you, sir.
Thank you. Thank you. And anybody, any doubts, you can feel free to contact. I am definitely there to help you out with whatever little knowledge I have in these things. Thank you.
Thank you, sir.
Right.